Good afternoon. I almost said morning. So as I thought about this conference and the tone of the conference, I thought of a saying from Buddha. And it is, chaos is inherent in all compounded things. Strive on with diligence. So today, as I go through the state's outlook, I'll talk about some of the very complex delivery systems that we have, the populations we serve, and hopefully that we are striving on with diligence through that process. I will start with an overview of Medi-Cal. I'm sure most of the people in this room are very familiar with this, but Medi-Cal currently serves about 13 million, almost 13.5 million people in California. That means that 1 in 3 people in California are on Medi-Cal. That's a lot of people. So we do have a budget of currently total funds is about $110 billion for Medi-Cal. And 82% of our beneficiaries now are receiving care through managed care. So we used to have a large number of beneficiaries in fee-for-service, and we have transitioned that to dominantly being managed care with 82%. We do that through 24 Medi-Cal managed care plans, one of which is also on the panel today, Cal Optima. And in managed care itself, we have about 75,000 physicians providing care to Medi-Cal beneficiaries, and that doesn't count those that also just provide fee-for-service Medi-Cal. So the delivery system is large. The number of people we serve is large, and that brings complex challenges and solutions that we're solving every single day. I wanted to at least bring some highlights regarding the state budget, though I will spend most of my time today talking through things that the state is focused on, either implementing in 2017 or coming up in 2018 to provide services to our beneficiaries and how that would impact payers, providers, as well as beneficiaries in Medi-Cal. So starting with the budget highlights, in the governor's budget that was just put forward, we are proposing a home health rate increase. The increase is a 50% increase. It's focused on the fee-for-service side of our house and our home and community-based services waiver. It would be effective July 1st. We will have to do a state plan amendment in order to implement this. And it would impact, and we would have to amend our 1915C HCBS waivers as well. We know that this has been something of focus across the state, and we look forward to implementing this increase. We also are rolling out Prop 56, which are supplemental payments for dental physician services, ICF-DD, our HIV and AIDS waiver, as well as women's health. We also just wanted to note that the current budget being posted did not represent for CHIP when Congress had not reauthorized CHIP when the budget hit. So that will be fully recognized in the May revise, noting that. I think one of the other pieces, the last few are about some changes that we're seeing. On the 340B drug billing requirements, Taylorville, the department does have significant concerns with how 340B has been implemented in Medi-Cal. We are currently recommending to prohibit the use of 340B within Medi-Cal due to a large number of duplicate discounts being charged, identified through various audits, as well as not being charged the 340B costs plus the dispensing fee. And this is currently proposed through the budget that is out right now. We also, due to a number of federal regulations that came down that impose significant changes to the way we do our hospital quality assurance fee, have some administrative changes that we're making at the state, have those in the budget. And then the last highlight that I'll point out regarding the current budget out is an expansion of our assisted living waiver, which is a home and community-based services waiver where otherwise individuals would be in institutions. By providing them additional waiver services, we can put them back in the community with safe wraparound services so they can reside safely within their homes. And we're adding to expand about 2,000 slots for that waiver. That was the budget stuff. Now I wanted to kind of really focus the majority of our update today in Medi-Cal Outlook on what the state has been doing in regards to our delivery system. The goal in the current focus of DHCS and Medi-Cal is to really focus on access and value, and really looking at better data to drive quality and compliance across this very complex system that we have. Many people in this room probably know, but there are multiple delivery systems in California. We have our managed care platform for the majority of our medical and surgical benefits with some mild to moderate mental health services. And then we carve out a number of beneficiary or benefits within our system into other delivery systems. Mental health has a separate delivery system. Substance use has a separate delivery system, dental, et cetera. And then we have a plethora of fee-for-service benefits that are available to people in managed care that are provided through a variety of environments as well. So one of the goals that we are looking at is, with the implementation of federal regulations, how we are able to standardize across those delivery systems. Whereas previously we had very unique systems, processes, policies within each of these delivery systems, which when you have multiple delivery systems, you have a complicated system. But when each of them has all of their own separate policies, procedures, it makes it even more complicated. And so one of the goals that we have been working on over the last few years and will continue is, how do we standardize that in a way across these delivery systems to make it easier for our beneficiaries to access care? So I'll go over some of our recent work and future work regarding the federal regulation implementation, how we approached it, the network adequacy proposal that was posted last year and will be going live July 1 of 18, and how we approach mental health parity. I also will kind of give a highlight to some of our delivery system programs that have been put in place or are going in place around some of our most complex patients in California. So CMS in 2016 issued the managed care final rule or final federal regulations, which are a number of provisions that had to be implemented over a number of years. And in California, we really dug in immediately to say, okay, where are we in compliance and where do we need to come into compliance? And through that process, in 2017, we implemented a number of things that were very important to beneficiaries. For example, in California, we standardized our member handbook because we were seeing as people transition through this process, information was being shared very differently. So we do have a standardized member handbook now. We implemented standardized grievance and appeals processes, one, to come in compliance with the regulations, but to also make sure we were providing that opportunity for our beneficiaries. And we started focusing significantly on encounter data. And that's a federal regulation, so we have to do it to come into compliance, but we've started really focusing on using encounter data to drive decisions within the department. And earlier I mentioned that we really wanted to focus on data, and encounter data is really important now that we have 82% of our beneficiaries in managed care. And as you may or may not know, in California, there are many layers. There could be there's a delegated model within our managed care plans. Many of people in this room are probably even a part of that delegated model. And the waterfall effect of that data is really important to the department. We need to know what services are being provided so that we can use that to drive policy decisions at the higher level. So there will be, and has been, and continue to be, a very large focus from the department on collecting good encounter data from all of our managed care plans. We also focused on program integrity in 2017, and we do this through a number of ways, whether it's a contract amendment to our managed care plans, what we call policy letters or all plan letters that get posted on DHCS's website. That's how we roll those things out. But we did that across all of those delivery systems. So we tried to maintain consistent policies across our managed care system, the mental health plans, the SUD or DMC ODS plans, as well as the dental managed care plans. So we tried to work as a department across the whole to ensure that we were being consistent with our policies as we rolled those out. We're continuing to do that with those items that are rolling out July 1 of 2018. So here you can see a number of the important pieces. However, there's two large ones that we have focused on. The first one is the provider enrollment piece, requiring that all managed care providers also become Medi-Cal enrolled providers, which is a large transition because not before you didn't have to necessarily be a Medi-Cal enrolled provider through that fee-for-service system. You could just be credentialed and enrolled through the plan. And so we have, and that became effective January 1 of 2018, so we're focused on that. And then network adequacy. And I'll get to that slide in a little bit, but we really focused on a department-wide proposal that went through stakeholder engagement last year and we'll go live July 1 of 18 to have a standardized network adequacy proposal across all of those delivery systems as well. And then lastly, as we move forward, 18 forward, we'll be focusing on quality. Hence, 17 really focusing on encounter data, getting those things in place. So as we move forward and to start developing a quality strategy and working on the quality rating system that we're still waiting for some guidance on, we will have the data we need to make those decisions and move forward from 18-19 forward. From a network adequacy point of view, California may be different than other states. We already had a large number of network adequacy standards within the state. We already had time and distance standards as well as timely access standards because of the way it works within both Knox-Keene as well as our managed care plans. But we came together as a department and put a proposal forward last year for public comment, presented a few times within the SAC meeting to present our proposal. And it will go live July 1. It is across all of our delivery systems. So here you can see it includes both primary care, it includes our mental health system, our SUD system, our long-term care system, our dental system. A lot of those categories were required through the federal regulations. However, we have standardized our approach across each of those delivery systems with how we were going to determine the time and distance, the timely access standards, and rolled those out. We will do and are required to do annual network certifications. So previously, we would receive provider files from our plans, all of the various plans, and we would have that information to ensure certain ratios were in place, as well as time and distance standards. However, now we must certify annually to CMS that our network will meet the needs of the beneficiaries that we have today, as well as the growth we will have in that next year, to ensure that those beneficiaries have access to the appropriate care that they need. And so we will be posting those things, and that will be very transparent as we typically are in California. The next major piece that we did to kind of ensure that we are looking at our system equally across was with the implementation of Medicaid parity. California stepped back and we did a very, very in-depth assessment across our delivery system. You know, some states have their medical, surgical, mental health, and SUD services all within one delivery system or being provided by one plan. That's not how it's done here in California. And so when you have multiple very separate delivery systems, ones that's driven by plans, ones that's very focused on counties, and other delivery systems, we had to look across that system to say, okay, where are our differences between our medical, surgical, and our mental health and SUD benefits? And naturally, on the managed care side, because of Knox-Keene and other state regulations, it was very prescriptive how things were done. Things were very detailed. Timelines were very detailed. Processes and requirements were very detailed. But there was a lack of that detail on the mental health and SUD side. And so through that evaluation, the department posted in October of 2017 our proposed compliance plan of how to come into compliance with mental health parity. And I'll go through a number of those provisions. I'm assuming majority of people in this room are familiar with parity, but essentially the idea behind it is that you are no more restrictive on the mental health or SUD side than you are on the medical surgical side. Across a number of categories, financial requirements is easy in California because we don't have copays, premiums, et cetera, in Medi-Cal. But we did have to look around any quantitative treatment limitations, non-quantitative treatment limitations, and the non-quantitative treatment limitations list is pretty darn long. And so we did a cross-department deep dive, and we've put forward a number of recommendations in California that will be implemented. Some have already started being implemented, and some will be implemented throughout 2018. For example, there will be statute updated regarding at the county level for unmet need determinations, ensuring that that's not applied to Medi-Cal beneficiaries, but only other beneficiaries or not at all. We also had some limitations regarding SBIRT, which is our substance use disorder screenings, in regards to how many a beneficiary could have, how many warm handoffs or brief interventions could be billed, as well as requiring training requirements providers to be able to bill such a service. So opening up, and we took a lot of those limitations away, and those have already gone live, to ensure that we aren't restricting screening for SUD services in a way that is not going to open up the opportunity for those beneficiaries to have access to additional follow-up care. We also are requiring that in the managed care plans for the non-specialty mental health services, or what we call in California mild to moderate mental health services, that there is no prior authorization needed for that initial mental health assessment. We saw a variety of implementations across the state, some where it was required, some where it wasn't, some where you had to go through this avenue to get to it first. And essentially, we removed those barriers by saying, for your initial mental health assessment, just like you can go to your primary care office today, there is no prior authorization requirement allowed in order to get that assessment to see if you need additional medically necessary services. The other piece that we identified and are in the process of revising is there were a lot of differences in regards to how the specialty mental health side was looking at prior authorization, retrospective authorization, and concurrent authorization. And so there will be a number of provisions where that will come more in line with what is done on the managed care side of things, where there are clear timelines, response periods, and it's consistently used having prior authorization, no prior authorization list that's being transparent to providers so that they clearly know what does or does not need prior authorization when it comes to mental health services, both inpatient and outpatient. And so those will also be rolling out in 2018. The other one is just to say we are standardizing across all of these delivery systems, the credentialing, the network adequacy, notice of action, and continuity of care provisions that we have in the state. We had a lot of continuity care provisions and safeguards in place for our medical surgical benefits that were not reflected on the mental health and SUD side. And those are now being a statewide policy across the board for all of the beneficiaries receiving services in that environment as well. So those were some of the examples of where the state has looked to standardize across all of our delivery systems in the aim to hopefully provide parity, but also a standardized process across. So now I'll quickly go into some of the services that we're also doing to focus on our most complex patients in Medi-Cal and what we're doing there. So under the 1115 waiver, we have what's called whole person care. Essentially here, we are looking at coordinating across health, behavioral health, social services. We have contracted directly with counties to do this service. They are responsible for working with the managed care plan, working with community-based organizations to provide comprehensive care management for these individuals. We have 25 pilots across the state. They're as small as 450 beneficiaries over 5 years to Los Angeles coming in with 150,000 beneficiaries that they're focused on in these whole person care pilots. The state's really excited to test some of the things that these pilots are testing because we really let them come to the table with very innovative ideas about how they could reduce utilization in very complex patients. So people with high inpatient and ER utilization, people with very strong specialty mental health backgrounds, and what are we doing to kind of drive that change? And we had a number of services that can be billed, whether it's fee-for-service or PMPM, through this demonstration pilot. Very kind of complex care management systems, tiered programs, as well as wellness and education. A large number of housing services are being built in. So almost all of our pilots have some type of a housing component to ensure that beneficiaries who don't have proper housing or individuals who are homeless are identified and have linkage to housing, even having a large number of flexible housing pools where there's local dollars being built and put into that. We have a very big focus on post-incarceration services, which we think is really important. So as people are being released from jail or prison, these counties are taking those individuals and ensuring there's an immediate warm handoff to the medical environment. There's a lot of data that shows if someone's released from jail and they no longer can get their prescriptions or they can't see the specialist that they've been seeing while they were incarcerated, they end up in the ER or they quickly get admitted to the hospital. These programs are looking at how do you do the immediate warm handoff to ensure that they get connected to our primary care provider, the specialists that they need, and most importantly, getting the medications that they need to in order to stay compliant to their next appointment and ensure that they stay out of the emergency room or inpatient stay. A lot of services around mental health, and then we're excited about mobile services, respite services, recuperative care services, and sobering centers all being a part of these pilots. For the department, we're wanting to see what is most impacting care for these individuals, these very complex patients with multiple chronic diseases, oftentimes homeless and or with mental health diseases, and how are we able to provide services, wraparound services, to get them the services they need, improve their health outcomes, and ultimately reduce utilization of inpatient and ER stays and institutions. We also will be launching our Health Homes project, which is happening across the nation. It will go live July 1, and we have a schedule of that rollout. It's a phased implementation, and that's on DHC's website if you are interested. We also, those first two programs are really focused on complex care coordination for our most complex medical patients, adults, but we're also focusing on children. So in California, we have somewhat of a bifurcated system when it comes to providing services for children. So if you have certain medical conditions, you're enrolled in what's called CCS, and you're carved out into the fee-for-service system. So you're enrolled in the managed care plan, but anything tied to your CCS condition is then paid for and coordinated through fee-for-service. So as a family, you can imagine how complex that would be to say, okay, for this service, I go to this plan, but for this service over here, I need to call the county and talk to my case manager. It creates a system that's very confusing for our beneficiaries. So we're launching what's called Whole Child Model, where we are incorporating that the plan be responsible for all CCS and non-CCS conditions. They would manage the entire child. We had put some protections in there for the families where there's additional paneling requirements for children with complex medical conditions that we require in California. Those are preserved through this initiative, as well as a large number of other protections around continuity of care and other things to ensure that these children transition well to getting those complex services in managed care. And lastly is the home and community-based alternatives waiver. So in California, we have a large number of what's called 1915C waivers. And it is how we ensure that people are getting transitioned from institutions and can reside safely in their home or in their community by providing additional wraparound waiver services for those beneficiaries. And in 2017, we launched a new model for the department's largest home and community services waiver, where instead of the department directly doing the case management and care management for those beneficiaries, we are contracting with what we call waiver agencies or local entities, 9 across the state, to provide enhanced care coordination at the local level, ensuring that those waiver services that they need are being provided to the beneficiary, being coordinated at the local level. We're expanding our provider network in those areas of long-term services and supports to ensure some of our most complex patients are getting the services that they need to reside safely in the community. So we're really excited about rolling out this new model for home and community-based services in California. We think it will be great. We have built in through the budget process expansion of that waiver to allow for more. We do have a wait list right now. So with the expansion of those additional slots, we're hoping we can transition more people from institutions, skilled nursing facilities, into their home by providing additional services so they can reside safely there. So those are the main pieces to kind of walk through in regards to Medi-Cal's outlook. I think, as we say, moving forward, I think the department, looking at a lot of the initiatives that we talked about on both adults and children, in the year to come, year and a half to come, we're very focused on care coordination. And what we are doing to provide a very clear framework and clear language to our managed care plans as well as our other plans about how to do that well within such a complex system. How do we make it to the beneficiary seem seamless when there may be different financial streams coming through to these delivery systems, but for the beneficiary, how do we make that less bumpy? And we also will be reprocuring a large number of our managed care plans in 2019 and 2020. And so the department will be really focused about what do we want as our delivery system moving forward in California to make sure we're giving access to our beneficiaries in a way that improves their health outcomes and improves quality for their lives. Thank you.